A very nice welcome from Innsbruck. My name is Peter Nopp, and I'm one of the directors in R&D, and I'm your moderator for today. Welcome to an Experts Online on the state of knowledge in anatomy-based fitting. We'll hear 4 experts that represent a variety of use cases and a variety of experiences with ABF. The goal of the Experts Online today is to give you out there really a good impression or a good idea about where we are in anatomy-based fitting. Before we start, we have a full program, so we need to rush on. Before we start, a few tips and tricks. Please name yourself, your name, your organization, and your country in Zoom, so that we all know who you are, so that people who ask a question or people who are answering question from the podium really know whom they are talking to. Please avoid any background noise. Mute your microphone and mute your phone. For a stable internet connection, close all other programs on your device. And most importantly, your comments and questions are very welcome. This is actually about answering your comments and questions and discussing your comments and questions. If you have any comments and questions coming up during the talks that we will be hearing, please type them into the chat. Later in the Q&A session, you can either again use the chat to ask your question, or you unmute yourself and just talk as you wish. There is also English captioning available. In the lower toolbar, you find the closed caption button, and you click on that button, and then captioning is switched on, and then you see, I think, automatic text about what's said. Now, to open the session, or to introduce the session in a sense, what we'll do is 2 Mentimeter questions. Mentimeter is a tool where you can answer questions and people see your response, depending on what the question is, either as text or as a yes and no bar. You'll see later. So to enter or go to Mentimeter, you scan the QR code on the left here, and you enter, or you go to www.menti.com. and you type in the code that's on the top, 34468066. So either you use the QR code, or you go to www.menti.com and you type type in the code that's on the bottom. On the top. And the first question is, what is your background? We would just like to know, is it all audiologists out there, surgeons, therapists? Let's just wait a minute so that people have a chance to type in. Clinical engineer, ENT. Okay, looks like most people are audiologists. That's a word cloud. You know, the bigger the text, the more answers in the respective category. Okay, so we have everybody from audiology to medical engineering, surgeon, medical engineer, physics, researchers, IT, computer specialists. Okay, a mixed crowd, and that's exactly what makes things interesting. And the next question is about the matter already, and it's just a yes and no question. Are you using anatomy-based fitting in your clinic already? Yes 2, yes 4, no 1. Okay. Okay, so most people in the auditorium do use anatomy-based fitting already. And that's good. And then I can really quickly jump over the next slide. And I don't need to really introduce anatomy-based fitting a lot. Okay. Now, what is anatomy-based fitting? And that's for the one who doesn't use anatomy-based fitting yet. Basically, the principle is to align the frequency bands in the MED-EL cochlear implant with tonotopic electrode frequencies. The tonotopic electrode frequencies are the green dots in the graph on the right. The gray bars are in that example the standard frequency bands in MAESTRO, and as you can see, the gray bars are off from the green dots. And this gap in between the gray bar and the green dot where the electrode is what's later called a place frequency mismatch or a frequency place mismatch. And the idea of anatomy-based fitting is to reduce that mismatch by getting the bars, the frequency bars, closer to the green dots, by adapting the frequency bars to where the electrode is in the cochlea, and that is the colored bars or the colored frequency bands in the graph on the right. And you usually do that in the MED-EL system in 2 steps. You perform a post-op analysis in autoplane, and that gives you tonotopic electrode frequencies, so the green dots as a function of angle. And then you also export that data, you import that data in MAESTRO, and then in MAESTRO you can click on anatomy-based fitting, and then MAESTRO automatically adapts the frequency bands to tonotopic electrode frequencies, and from there you can work on. Yeah, some people shift lower frequency limits up, as you will be seeing later in one of the talks. This is an initial anatomy-based fitting from which you leave as it is, or from which you work on like you do in normal fitting. Okay. Anatomy-based fitting is out in the world, so to speak, on the market from our perspective for a while already, and a number of researchers and a number of teams worldwide really is working on that. From Saudi Arabia to Germany to Italy to the US, Belgium, France, Japan, Spain, everywhere. And we'll hear from 4 of those researchers today. I'm naming all of these researchers in order to honor all of them, but we can only have a few of them speak in order to not, talk for a day or even longer. So the 4 talkers you will be hearing today really represent a wide variety of researchers that look into anatomy-based fitting from all aspects. Now, over the past few years, anatomy-based fitting has been tried out in a few use cases. And there are use cases where anatomy-based fitting has demonstrated benefits already. And that's cases where the cochlear implant is actually, or needs to be actually coordinated with another hearing entity, another hearing modality, like acoustic hearing in the same ear, which is then EAS, a contralateral CI, like in the case of bilateral CI, or with contralateral acoustic hearing, like CI and SSD, and bimodal stimulation. And about a few of those use cases you will be hearing today. There is other use cases where the picture is not yet that clear. And in particular, that's the case of a unilateral CI in a bilaterally deaf person. And you will be hearing about that use case also today. So you'll be hearing about things where the benefit has been shown already. And you'll hear about things where finding benefit is a bit more problematic or not so easy because there isn't a reference ear or a reference to compare the cochlear implant to. And again, that's also the purpose for today, represent a variety of use cases, a variety of research, so that you can really get a good idea about where we are. We have really 4 distinct speakers, 4 really well-known experts in cochlear implant in general, cochlear implant fitting in general, and in anatomy-based fitting in particular. We have Margaret Dillon from the University of North Carolina as the first talker, Anja Kurz from the University Clinic of Würzburg as the second speaker, Emilie Heuninck from the University of Brussels, number 3, and last but not least, from Spain, from La Paz University Hospital, Luis Lassaletta. Okay, we'll start with Margaret Dillon right away. Margaret Dillon is Associate Professor and Director of the Cochlear Implant Research Center at the University of North Carolina. And she'll be talking about influence of electric frequency to place mismatch on performance for CI users with functional acoustic hearing. Meg, please. Welcome to the show.
Good morning from North Carolina. I'm excited to be here. This is one of my favorite topics right now, and to share some of the data that we've been seeing at our center. I'm going to be talking specifically about patients with functional acoustic hearing, either in the implanted ear or the contralateral ear. So for the folks that have functional acoustic hearing in the implanted ear, these are those that are referred to as bimodal users, so cochlear implant plus a hearing aid. And then for those that have it in the implanted ear, those are our electric acoustic stimulation users. So first, I wanted to share some data from some bimodal users that we were looking through. This was a study that was not intentionally designed to capture an effect of frequency to place mismatch, because the assumption was that these patients had been listening to bimodal stimulation for over a year. And so, what we think of right now when it comes to electric frequency to place mismatch is that they should acclimate to this. And usually you'll see this within the first couple of months of device use, but really by long-term use, you should be able to acclimate to these mismatches between the electric stimulation and your cochlear place frequency. So these were bimodal users. They were all adults at the time of test. We had their contralateral pure tone average of 65 dB or better, and they all had at least a year of bimodal listening experience. And our goal was to see if we matched the processing speed of the CI to the contralateral hearing aid, would they have a benefit on speech recognition in these spatially separated noise conditions? And we wanted to see if that benefit interacted with the amount of frequency to place mismatch that they had. So what we did is we put them in the sound field, and they were tested with AZ biosentences at a 0 dB SNR and a 10 pocket masker in 3 spatial configurations. So the speech was always from the front, and the masker was either co-located with the speech 90 degrees towards the cochlear implant ear or 90 degrees towards the hearing aid ear. And they were evaluated in 2 conditions, with the processing delays of the cochlear implant and the hearing aid mismatched, which is the default fitting, or with them matched, which is a tool that you can now use in the MED-EL software referred to as bimodal synchronization, where you can slow the processing speeds of the cochlear implant so that it matches the contralateral ear. So just jumping right into the data. So what we have here is in our left-hand corner or column, this is our mismatch condition. In our middle column here, we have the match condition, and then we have a comparison between the two on the third column, or the column on the right. On the top, we have speech front noise towards hearing aid. Middle is speech front noise front, and then the bottom is speech front noise towards the cochlear implant. Higher values indicate better performance on this task. And then we have on this axis mismatch on that most apical contact. So if it's 0, then we have a match between the center frequency of the most apical contact and that cochlear place frequency. And then as we start to get further and further away, we have greater values. This is in semitones, and 12 semitones is an octave of mismatch. So what we see first, which was the intent of the study, was we see this benefit of when we turn on bimodal synchronization, we match the processing delays at the cochlear implant and the hearing aid. We see that patients benefit, and they benefit across this range of frequency to place mismatch, which is great. We're glad that if we use that tool, that we can help patients achieve better outcomes, specifically in this speech front noise towards the hearing aid condition. But what we weren't expecting is that we are continuing to see this negative effect of electric frequency to place mismatch in these patients that are long-term users. So one of the takeaways that I wanted to have with this particular data set is that there may still be this long-term influence of electric frequency to place mismatch in our cochlear implant patients. The range of bimodal use in this population was 1 to 13 years, with a median of 5 years, and they still are showing this negative effect with if you have greater magnitudes of mismatch, you have poorer performance. And so we think that this is telling us that we should be considering our electrode array placement when we are programming the device. And 2 points to make here is the majority of this sample were flex soft, that 31.5 millimeter array, full insertions. So we can't just assume if you've put in a long array that that default filter is going to align with cochlear place. And that also we're seeing an effect in a fairly narrow sample. I mean, this is a group that has a median of 3 semitones of mismatch, which is pretty small. If we look at the literature, the average mismatch that you see across cochlear implant recipients is an octave. So we're really looking at a pretty narrow scope and still seeing these effects. So I think that that's important to consider with mapping. Now, one point that I want to make, and we can have this in the discussion later, is there are multiple ways that you can approach mapping to cochlear place. The two that we're talking about in this session are anatomy-based fitting, which is what's offered with the MED-EL software. And then what we're using at UNC is what we're referring to as place-based mapping. Now, these really are just semantics, right? It's all about how we are doing it. With anatomy-based fitting, the biggest difference between that and place-based mapping is what frequency information is being mapped to place right out the gate. So with anatomy-based fitting, the priority is that critical speech frequency range, so between 1 and 3 kilohertz, taking that frequency filter and matching it to cochlear place for those contacts. With place-based mapping, we also prioritize the low frequency information. So we're doing everything up to 3,000 hertz. Now, you can imagine the benefit of place-based mapping or anatomy-based fitting is that you're still providing the patient with the full speech frequency range. But with place-based mapping, we are being aggressive in cutting some of that low frequency information. So for someone who has a shallow placed electrode array, like what we see depicted here, where this most apical contact is around 525 hertz, we, in place-based mapping, are discarding all of that low frequency information and starting at 525 hertz and aligning everything up to place to 3,000 hertz. Whereas with anatomy-based fitting, you would be giving them that full piece of information by providing that low frequency information. So what I want you to take away from this, we did a simulation study to see really how aggressive is this between aligning to place in the low and mids versus just the mids, providing more low frequency information. And we saw that there was this benefit for place-based mapping up to around 987 hertz. So again, simulation study, jury's still out. And for the audiologists in the audience, you're probably thinking, well, Meg, I can adjust the filters in the anatomy-based map. So can I just do that if I want to align more low frequency information? And the answer is yes. The default for anatomy-based fitting is to match that low or mid frequency information. And if you want to adjust the lows to match that as well, then that's an option that you can do in that system. So now for our EAS users, so now functional acoustic hearing in the implanted ear, these folks are part of a prospective repeated measure study that we have been conducting, where we are including adults between 18 and 80 years of age, you're a recipient of a MED-EL device, and you pass the MMSE. So we really wanted to be representative of our clinical population. And they are randomized at activation to receive either the default filter frequencies or what we're referring to as a place-based map. And they listen to that exclusively through the first 12 months of listening experience. It's double-blinded, so the participant and the testing audiologist are unaware of what that specific map is. Again, jumping right into the results, these are some preliminary results that we published last year. And this is vowel recognition and CNC word recognition with the EAS device alone. So either direct input or with masking delivered to the contralateral ear. On the top panel, we have performance at the 1 month interval. On the bottom, that's performance at the 6 month interval. Again, higher values indicate better performance. And we have absolute mismatch on our x-axis again with 0 indicating a match between the center frequency filter and the cochlear place frequency. Open symbols are the folks that have been randomized to place, and then the filled symbols are the ones that have been randomized to default. But what we can see is that for those that have less mismatch, either in a place-based map or just end up with that with their default map, we can see better performance even out to 6 months of listening experience. And with those that have greater magnitudes of mismatch, we see this wider variability in patient performance. So we think that this is telling us this is something we need to be considering to help each individual achieve their best outcome. We've also been looking at performance in the bilateral listening condition, and so these are some newer data. Here again, we have our default recipients are in the open symbols or open box plots. Our place-based folks are in the blue because we love our Carolina blue at UNC. Better performance is indicated by a higher value. This is speech recognition in a 4-talker masker. And we have performance at the 1 month, 3 months, and 6 months. In this panel, we have masker towards the implanted ear, center is co-located from the front, and then the right is masker towards the contralateral ear. And generally what you're seeing is that for those that are in place-based maps, so have less mismatch between what's being delivered with the cochlear implant and the cochlear place frequency, we can see better performance early at a month, but we see that they're continuing to have better performance even out to 6 months. So it might not be that they are acclimating to this input. So in summary, for our functional acoustic hearing folks, either bimodal users or EAS users, for our bimodal users, we're seeing evidence of negative influence of electric frequency to place mismatches on even long-term outcomes. Again, the median of that sample was 5 years. Some were out to 13 years. And in our EAS users, we're seeing evidence of better performance when electric mismatches are small, either with a place-based map or with default maps that just end up in smaller magnitudes of mismatch. And if we eliminate that mismatch, we think that we can help patients achieve better outcomes with their device. And so with that, I'd like to thank our funding sources as well as our study team at UNC. This is a big project and really glad to have the work of our surgeons and audiologists and researchers to make this happen. Thank you.
Okay, great. Thanks a lot. Thanks a lot. Very interesting. So positive results in bimodal users and EAS users. We'll jump right to the next presenter, Anja Kurz from the University Clinic of Würzburg, where Anja is head of audiology and technical director of the Würzburg Comprehensive Hearing Center. Anja, the floor is yours.
Thank you. Well, good afternoon also from my side. It's a pleasure to be here. It's now 3 o'clock in the afternoon. So I would like to give you some input into our experience of using anatomy-based fitting in bilateral CI users and in single-sided deafness. So the questions that I would like to answer today is, I would like to share is, what are the benefits of using anatomy-based fitting? And the big question, is it really a suitable tool for every CI user? And are there some conditions where it's working or not? So when we are looking at the bilateral CI users, we have the same frequency filters on both sides, regardless of the electrode type, electrode length, and so on. When we are talking about the acoustic dynamics, we know in a normal hearing ear, we're hearing from 16 to 16,000 hertz. So when we're then using a cochlear implant sound processor, we only have the electric dynamic of 70 to 8,500 hertz. And as I just said, regardless which type of electrode I have now implanted, it's always this range that I'm allocated to. So the idea is to have some tonotopic matching. And the idea of using anatomy-based fitting in my data is to actually use the frequency filter and shift it to the place where it really takes place. So this is something that Meg just referred to as place-based mapping. So that's also the idea that we are using here in our data. And that's the way how we were conducting our study. So I had a study with 10 participants, and you can see they have different electrode lengths and different insertion depths. We're looking at the angular insertion depth of E1 of the first electrode contact, and we're getting that kind of information from the post-operative CTs. We were asking those patients, they were all sequentially implanted, do you have a better ear, a subjective better ear? And that's what we call the reference ear. So we started using our approach of anatomy-based fitting, really looking where's the contact, to really place the filter over the contact where it really takes place, to have a place-based mapping. And we were then testing speech and quiet to start with. So for the reference side, you see, okay, is there a difference between the standard mapping and the anatomy-based fitting mapping that we were then measuring after 3 months of acclimatization? We saw there was kind of some improvement, but it was not significant. For the reference ear, well, there was really something happening. As you can see, for some of them in the contralateral ear, the speech perception got poorer. But interestingly, in the bilateral situation, so the situation that we encounter every day, because our recipients, they hear with 2 sides, we can see that the effect in quiet is significant. So it really made a difference for speech perception in quiet. Interestingly, when we're looking also at speech perception in noise, we were calculating binaural effects. So we were calculating effects like the summation effect, squash effect, spatial release from masking, and so on. And what you can see here is there a difference when we use a different kind of mapping? The higher the dots get, the better the speech perception is. And we could see, okay, there was no summation effect if we're using our approach of anatomy-based fitting for speech and noise. For squash, what it looks like that there is no effect, but there's one outlier. And if we take it out, well, we have a significant squash effect. And the same for spatial release from masking. So we could really see a difference in our bilateral population by using this kind of approach. So for sound quality, as you can imagine, where we are really shifting, we're really doing something with the frequency filters. And yes, there were some people that didn't really like the new way of fitting. That's what you can see here in the HISQ. Not everyone really liked the fitting, but we could see, okay, we have now binaural effects with that kind of mapping. So is there a benefit? Yes, I would say yes. In bilateral CI recipients, we do have binaural effects when we use this kind of approach. Is it a suitable tool for every CI user? Well, there's something we had to learn, because it seems there is a rule behind, because not everyone liked the way of how we were shifting the filters of really applying anatomy-based fitting. And it seems that the rule is we need access to the apex. We need apical stimulation, at least in one ear, to apply anatomy-based fitting, and then match the second side to that. And if we have that, acceptance was great. We have a better speech perception in noise, as you can see, and also in quiet. So how do we see it? We think that it is a really useful tool, especially for unsatisfied experienced CI users. And for the new users, well, we are just in the process of collecting our data because we changed our paradigm. So this means that everyone got anatomy-based fitting right from the start, and we started last summer. So there are new data to come up soon. So what about SSD? Well, in the SSD, we have a normal hearing ear, and then we have a cochlear implant on the other side. Here again, sometimes we have a full cochlear coverage with a longer electrode. Sometimes it's a bit shorter. Sometimes even really, really short, because there was some residual hearing and we were thinking, okay, it might be an EAS candidate and so on. And again here, the idea is to use anatomy-based fitting in a way to really place the frequency filter over the actual electrode contact. So we had here a population of 12 CI recipients. And as you can see here, where we really had a difference in the insertion depth. So it's spread all over. All these patients had a postlingual deafness, and their average hearing experience with the CI was 2.8 years. So we had again the same procedure as with the bilateral ones. They came into the clinic, we tested speech and quiet, speech and noise, so on, did the anatomy-based fitting, sent them home this time for 1 month. And what we could measure afterwards, when we again looking at the binaural effects, we could see that by using that kind of approach, we had a significant summation effect, and we had a significant squash effect by using that kind of fitting. For the HISQ again, as already learned with the bilateral population, not everyone likes that way of fitting. Maybe these people are more accustomed to the clinical weighted clinical mapping that they've heard now for, let's say, 2 or more years. So not everybody likes it in general, but it's worth trying it. So again, answering the question, is it a suitable tool for every CI user? Well, it seems, especially in the SSD population, it seems that there is no precondition of using, of applying anatomy-based fitting. And so we see this as a big opportunity to actually try it in this population and to actually give it a go and see if sound quality immediately increases or not, because you get an immediate effect when you do that kind of mapping straight away. So I would also like to thank my team that is collecting all those kind of data, and there are more data to come soon.
Okay, thank you very much. Thank you. So, so positive results or benefits also in bilateral CI users and in CI users with SSD, with some caveats, and we'll discuss that later, of course. Next on the list is Emilie Heuninck. Emilie is a research audiologist from the University of Brussels. She also works with the University of Antwerp, and she'll talk about anatomy-based fitting in unexperienced cochlear implant users. Emilie, the floor is yours.
Thank you. Thank you for the introduction. I am pleased to present today our preliminary results of our study on anatomy-based fitting that we performed at the University Hospital in Brussels. So the goal of our study was to assess the effect of anatomy-based fitting on speech and music perception in unexperienced, unilaterally deaf, bilaterally deaf, unilaterally implanted cochlear implant users. Our study is a prospective longitudinal study and has a parallel setup. So at the activation of the audio processor, either an anatomy-based frequency distribution or a default frequency distribution was assigned to the enabled electrodes. Currently, we are including adult patients with a bilateral severe to profound sensorineural hearing loss that comply with the Belgian reimbursement and candidacy criteria. All patients need to be recently implanted, and the electrode insertion angle needs to be further than 540 degrees. The audiological assessments consists of the minimal outcome measurements, or MOM, which is a set of quality standards that is developed by the hearing group. MOM consists of pure tone audiometry, speech audiometry in quiet, speech audiometry in noise, and the HISQI 19 questionnaire to evaluate the degree of self-perceived auditory benefit. Furthermore, we included a harmonic interval perception task during which patients need to rank the pleasantness of harmonic intervals, and all tests were performed either pre-operatively or 1 week, 1 month, 3 months, or 6 months post-activation of the audio processor. Until now, 23 patients have been included and are followed up for a period of 6 months. 11 patients have been fitted with an anatomy-based frequency distribution, 12 patients are fitted with a conventional frequency distribution, and we determined multiple parameters for both groups that could confound with the outcome, such as use of a hearing aid pre-implantation, the age at implantation, and the etiology. All patients, they underwent cochlear implantation with either a robotic access to the cochlea with the Hear Robotic system, or a conventional access to the cochlea, which is defined as a mastoidectomy in combination with posterior tympanotomy. The electrode insertion angle was very similar among both groups and was 640 degrees on average. Statistical analysis was performed on the data using generalized linear mixed model to assess the effect of type of fitting on the different outcome variables, taking into account multiple confounding factors, such as the use of a hearing aid, the etiology, as explained before. We included patients as a random factor to control for repeated measures. Here on the slide, you can see the outcome for pure tone audiometry and speech perception in quiet. So the pure tone average is displayed on the left y-axis, and the percentage of correctly repeated phonemes is displayed on the right y-axis. There are no significant differences between an anatomy-based frequency distribution and a default frequency distribution in terms of pure tone audiometry and speech perception in quiet at 1 week, 1 month, 3 months, and 6 months post-activation of the audio processor. Speech perception in noise was performed using the Dutch list or the French FIST sentences in an adaptive procedure to determine the speech reception threshold, which is displayed here on the left y-axis. The level of self-perceived auditory benefit was quantified using the HISQ-19 questionnaire, and the improvement in HISQ-19 score was calculated in comparison to the preoperative HISQ score for each time point. There is, again, no significant effect of the type of fitting for speech perception in noise and self-perceived auditory benefit. In this study, we asked our cochlear implant recipients to rank the pleasantness of harmonic intervals. And what is a harmonic interval? A harmonic interval is perceived when we listen simultaneously to two sounds. And the relation between the fundamental frequencies of those two sounds, they determine how pleasant a sound is perceived. And in a musical context, this is referred to as consonance and dissonance. However, when the perception of harmonic intervals is distorted, a musical piece or polyphonic music will not be perceived as intended by its composer. So during the experiment in our study, the CI recipients, they heard multiple sets of 2 harmonic intervals, and they had to indicate which of the 2 harmonic intervals sounded most pleasant. And via midpoint comparison procedure, all stimuli or all harmonic intervals were ranked according to pleasantness. The pleasantness rank you can see here on the y-axis for both conventionally fitted and anatomy-based fitted patients in function of the harmonic intervals. So what would we expect in normal hearing listeners? In normal hearing listeners, several studies have shown that a distinct pattern for pleasantness can be observed. For example, a difference of an octave or a perfect fifth or unison would be perceived as pleasant and is displayed here in green, whereas a difference of 11 semitones, which is a major seventh, or 2 semitones, which is a minor second, would be perceived as most unpleasant. So in our study, we found that the pattern is more pronounced in patients that are fitted with an anatomy-based frequency distribution, and that the pleasantness is ranked significantly higher for the perfect fifth and significantly lower for the major seventh for patients with an anatomy-based frequency distribution in comparison to patients with a conventional frequency distribution, and this at 3 months and 6 months post-activation of the audio processor. We further analyzed the results in terms of the frequency to place mismatch. And when the frequency to place mismatch is lower, the pleasantness is ranked significantly higher for unison, for an octave, and significantly lower for the major seventh. So the smaller the frequency to place mismatch, the closer the perception of harmonic intervals to the perception of harmonic intervals of normal hearing listeners. So to conclude, our preliminary data shows similar outcomes in bilaterally deaf, unilaterally implanted patients with a conventional or an anatomy-based frequency distribution, and this in terms of speech perception and self-perceived auditory benefit. However, patients with an anatomy-based frequency distribution, they show a more distinct pattern for pleasantness of harmonic or vertical musical intervals in comparison to conventionally fitted patients. So the lower the frequency to place mismatch, the better some aspects of harmony are preserved, which are crucial for music perception and appreciation. So please note that the study is still ongoing, and the effect of anatomy-based fitting on speech and music perception will be further explored in the near future. I would like to thank you for your attention, and if you have any questions, I would be happy to answer them.
Okay, thank you, Emilie. We'll do that after the next talk. So this was number 3. And while the first two talks were about those use cases where benefit seems to be clear already, this one talk and the next talk is about the one use case that I mentioned before, where benefit is maybe not so clear, where the discussion is ongoing, and we'll see whether where the benefits in those people are, whether we found the right tests already, and where the journey goes, and we'll see. And that's exactly also the issue that Luis Lassaletta from the University Hospital La Paz in Madrid will be talking about. Anatomy-based fitting, do we have the appropriate test to demonstrate its benefit already? Luis, please.
Thank you very much. It's a pleasure to be with you today here from Madrid. I'd like to share with you our experience with anatomy-based fitting at La Paz University Hospital in Madrid, but specifically to discuss if we really have the appropriate test to demonstrate ABF fitting, and particularly in this subset of patients you were mentioning. So our first study was entitled, Does it make any sense to beat cochlear implant according to the anatomy-based fitting? So in this study, we analyzed adults bilaterally deaf with just unilateral implantation, a MED-EL Flex 28. Then what we tried to find out if there was an objective preference with ABF. So following the CI activation, the patients had the ABF for 9 months. At that time, we performed both speech and subjective tests, and then we switched to standard fitting for 1 month, and again, we tested speech and subjective tests. And the patient was asked if he or she preferred anatomy-based fitting or standard fitting. The results we had were very similar to what we just heard from Emilie in Brussels. So we could not demonstrate significant difference in objective or subjective tests, but interestingly, there were almost 90% of the patients that subjectively preferred ABF to the standard fitting. So the next step was trying to find another way of evaluating these patients, and we tried with music perception. So I'm sure you're familiar with the Meludia. Meludia was intended as a training tool, but you can also use it as an evaluation tool. So we used the easiest level, the discovery level of the Meludia, which has 5 tests with 5 levels of difficulty. And here we compared 2 populations, 8 patients with ABF and 8 patients with a standard fitting. So as you can see here, they are very similar in terms of age, speech discrimination, and CI use. So just to show you one of the preliminary results, you can see that patients with ABF needed less attempts to complete the level of density. Density is a comparison of one sound versus more than the one sound. And this is something that is more related, or what we can, discriminate with the ABF. This was our intention. So what have we learned so far with this kind of studies about ABF? The first thing, I think it's very easy to understand the concept of ABF. Everybody will understand that if you fit a CI which fits better this frequency discrimination, this would result in better outcomes. But there are still things that we have to consider. I think the first one is that when you are trying to compare groups of patients, let's say a group of patients with ABF and another group of patients with a default fitting, you have to consider also other prognostic factors that have an impact on CI performance. Some of them are non-modifiable, time of onset, age of implantation, etiology of deafness. The patient comes with that characteristics you cannot modify, but others you can modify. You have surgical possibilities, electrode choice, and you have the fitting. That's where we're talking today, but also we have to keep in mind the importance of rehabilitation. So there are a lot of prognostic factors, and you really have to control all of them if you want to demonstrate the benefit of ABF when comparing two subsets of patients. That's what of the consideration. And the other is about the best test to demonstrate this. So we have used objective and subjective tests. I think most of the people are using speech discrimination, of course, in silence, but sometimes in silence it can be too easy and you can have a ceiling effect. It's more recommendable to use speech in noise. We have used adaptive tests too, but I have the feeling that not by making this test more difficult, you'll be able to discriminate better and show the ABF benefits, especially in this kind of bilaterally deaf, unilaterally implanted patients. You can use, we have seen quality of sound as the HISCI or quality of life questionnaires. Here, the problem is that you cannot isolate the effect of each ear individually. You can use the subjective preference, just he or she prefers ABF or the standard. So this is simple, but I think this is effective. And you can use music perception, which is what we are working on right now. But again, when you're looking at music perception, you have also to consider there are some subjective aspects about musical background or even personal interest that can also impact the outcome. And whatever test you use, objective or subjective, here the problem is that you have the adaptation over time. We think that this is particularly important in this subset of difficult patients of bilaterally deaf with unilaterally implanted, in which they have nothing to compare on the other side, and adaptation over time maybe will eliminate any difference that you can see at the beginning with one or other feeding method. So in conclusion, I think we've seen very nice presentations today. There's more in the literature. We know from several studies that there is a benefit in CI outcomes with the ABF. In our experience, at least this preference is clear. That the patients really prefer ABF, and they tell us that it's more natural what they hear, especially with the music. ABF demonstrates some specific musical advantages, not for all the tasks, but mainly those related to processing multiple sounds simultaneously. Again, as I said before, we have to keep in mind and control other variables with an impact on CA performance, not only the fitting that have to be controlled. And I think we need further studies to explore these additional benefits of ABF, particularly in musical skills. So that's it. Thank you very much.
Thank you very much. Thank you, Luis, and thank you to all those to all the speakers. Before I provide a short summary from my perspective, and then we'll go into the discussion very quickly. I think this is something it seems that you can't avoid in an Experts Online. We'll do a group photo. So maybe we can do that in a minute and not lose too much time. So for the group photo, you switch on your camera, and then they switch over to what they call gallery mode. And I see a lot of known faces here. Hey, it's really great to see you all. Somebody's even in the car. Be careful when you drive. Okay, is that the best gallery you can do? Okay, so we'll do a quick screenshot. Tash, tash. Okay. That's not all. Can you do the other gallery as well? Okay, we do a second one. Okay. Let me know when you're done. Third one. Okay, I can see Dala from the US. Done? Okay, good. Good. Thank you very much. Thank you. Thank you. We'll publish that. We'll publish that. Okay. We have 10 minutes to discuss, maybe 15. From the speakers, we have the okay to run over a bit. I've also told the speakers, like every one of you, if you need to leave, if you run over and you need to leave, just run away. If it's getting too long for you, just run away, and I'll make sure we're not running over by more than 5 or so-ish minutes. Okay, what we've seen, I think, from my perspective, is really the following story. If the cochlear implant needs to be coordinated or customized or whatever to another hearing entity, like like ipsilateral acoustic hearing as in EAS, or contralateral acoustic hearing like in bimodal or CI and SSD, or like a contralateral CI, like in bilateral CIs, then with ABF you can better coordinate between the CI and the other hearing modality, and that's where the benefits have been shown. You know, MEG, EAS, unilateral and bilateral, bimodal binaural hearing, and Anja with binaural hearing for CI and SSD, and bilateral cochlear and bilateral cochlear implants. So wherever the CI needs to go together with something else, ABF seems to work or provide benefit, at least in quite a few cases. In the one case where the CI is not working together with something else, like in a bilaterally deaf user with only one CI and nothing on the other side, there is nothing to coordinate to. And that's the more problematic case, because there is nothing where the CI needs to be in tune with, so to speak. And here the benefits are not yet so clear. There doesn't seem to be a benefit in speech perception, although a group from China has published data with a benefit in speech perception, but that's for a tonal language. So maybe there's a difference between Western languages and tonal languages in this regard. But what's interesting that in that group of users, in postlingual users of that group, of course, if you better tune to the CI to the natural tonotopicity, and that's the tonotopicity that these people developed or maybe had from birth on, then at least sound quality is getting better, personal preference is getting better, like we've heard from Luis Lassaletta. And if you do a music test, music listening is getting better, either with distinguishing between one tone being played simultaneously and more tones being played simultaneously, or the consonance dissonance perception is getting more natural. So this is really basically, I think, where we are. And now let's discuss about where we are, and let's discuss about where you think we should go, where you think where we are, and where your ideas are about ABF. Can I ask, do we have questions in the chat? I'm just asking my director here. Okay, quite a few questions in the chat. I'll do them from bottom to top, right? And then first question, what do patients say when you switch them between default and ABF fitting? And that's experienced patients, I guess. And as far as I know from that aspect, that's the more difficult group. Does any one of the four speakers, Meg, Anja, Emilie, Louis, want to comment on this one?
Well, I would like to comment on that one.
Yes, please.
Well, I believe it really depends on the type of apical access that you have. If you have a complete cochlear coverage, and if you have access to the apical region, so this means that your E1 is below 200, 230 Hertz, in the MAESTRO fitting software. If you then push the button to apply anatomy-based fitting, the frequency filter changes is not that big. So people will say, okay, yeah, it sounds a bit better. Yeah, let's give it a try. You will see a huge effect if you have shallow insertions. And you can see that easily in the MAESTRO screen when your green dots start somewhere in the middle of the page and you see the frequency filter are really somewhere else. If you then push the button of applying anatomy-based fitting, you see a huge frequency band for E1. And of course, this does not sound nice. And this was at the beginning when we started, doing all this experiments with ABF. It was like, okay, we need to really match, we need to shift that filter to actually place it to where it belongs to. But even then, it was kind of tricky. Then you need to match it to the other side. So this really shifting the frequency filter is just accepted if you match it to another electric stimulating side or a normal hearing. It really depends of where is E1, if ABF is immediately accepted and a success or not.
Okay. Peter, can I follow up on that just for a second?
Yeah, so, yes, of course. Yes, of course.
We didn't share, or I didn't share these data, but we've been doing this in some of our long-term users as well. And we have a lot of folks that have the 31.5 millimeter electrode array. And again, we are matching low and mid frequency with our approach. Like what Anja was saying, if you have a shorter electrode array with ABF, because it's prioritizing giving the full speech spectrum, you're going to have to move up that low frequency filter if you want to align it to place. And what we're seeing with some of our long electrode array patients is it's not always this aha moment. Some of them have been very close, and to the point between the default filters and the place-based filters where I would have thought they're not going to perceive any difference. And then they do, and it's a mixed bag of whether they like it or they don't like it. And what we have found is that it might take a couple of months before we see this big benefit in speech recognition. And I'm thinking of one gentleman who's bilateral, standard electrode arrays on both sides, full insertions. We're talking maybe 2 to 3 semitones different between the filters that we have with the default, which he'd had for 7 years, and then the place-based map. And at 6 months of listening to that, we saw this like 30 to 40% jump in his speech recognition, which he also noted this improvement in music sound quality and other things where he came in, he was like, something has synced between the ears and it's now working again. So my only point in bringing this up is just because a patient says right out the gate that they don't like it, that doesn't mean that they won't benefit from it. And it's could be related to their duration of experience that they've had with the default filters. We haven't necessarily seen that piece yet, but it's just something to consider that they might need a little college try to get that going.
Okay. I think both Anja and Meg really are touching on in that regard, in regard to the question, on a really an important point. Anatomy-based fitting cannot compensate or correct missing cochlear coverage. I mean, that's really an important thing. If we don't have electrodes in the electrode contacts in the second term, or in the second half of the second term, then anatomy-based fitting cannot represent the low frequencies where they should be presented, right? Because there is simply no electrode to stimulate that region of the cochlea. So what then anatomy-based fitting does is squeeze the filters or extend the filters so the entire frequency range is still covered in MAESTRO, and that's then resulting in the wide filters, in the wide apical filters for those short insertions that Anja mentioned. So really one of the preconditions of anatomy-based fitting from my perspective really is decent cochlear coverage. We haven't talked about cochlear coverage in this session, but it is really the number one rule really is in a cochlear implant, cover as much of the cochlea as you can. And Otoplan helps in that process. And then if you want to go further and further reduce frequency place mismatch, then you perform anatomy-based fitting. But the cake really is cochlear coverage, and anatomy-based fitting is the icing on the cake. Okay, next question. Can you move up, please? We'll talk about certification later, or you can answer that in the chat. Okay. Is there more in the chat? No. Okay. I have a few questions prepared. Let's just go on with 1 or 2 more questions and then let's close. From all your experience, Anja, Meg, Emilie, and Louis out there, what's the biggest challenge in anatomy-based feeding from your perspective? Any one of the four, or anyone from the auditorium?
Well, I would say, as you are commenting now, we need to find the correct patient. Again, focusing on these difficult patients which are bilaterally deaf with unilateral implantation. As you say, we have a full insertion. It would be great to do ABF, but we already know that those are the patients that have the better outcome. So for me, the biggest challenge is to know exactly where's the limit. So how shallow can be an insertion to know that ABF can make a difference for that particular patient. I think that's one thing, and the other thing, I think we have to simplify all the methods around the ABF with the CT scan, the other plan, the fitting. Now I think now it's very time consuming, and I think it should be more simple in the future. I think for me that would be the two biggest challenges.
Okay. So number one is to find out in the group that you're addressing specifically, what's a good candidate for ABF and what's not a good candidate for ABF. And the second one, yes, is another question that I have on my list. And this is really, ABF makes fitting more complicated. And what can we do to make it easier? We're working on those things. And we'll see what we can bring out in the future. Now, regarding the question, biggest challenge, is there anything from anybody else? Anja, Meg, Emilie?
I mean, I think I would add
go on, Meg. Yep.
Is that, there are different approaches to doing this. So ABF starts with those mid frequencies, but is the mid frequency information alone enough? Should we be aligning the lows? Should we be aligning the highs? And is that benefit different for different types of patients? And I think there's more to be learned about the best way to individualize the map, how that could relate to a specific patient population when we're thinking about aligning to place.
I think you mentioned a really important word, and that's learn. Anatomy-based fitting is more or less the first attempt to fit the CI not only in loudness and in terms of front-end processing, but also in terms of pitch. And we're at an early stage. I remember when I started working in cochlear implant almost 30 years ago, people discussed how to measure MCL or C levels. And that's sorted out now. Everybody knows how to do it, and everybody has his own maybe way that differs slightly between audiologists to come up with decent MCL values. And I think we're in a similar stage for pitch fitting of a CI. So we need to learn how important the low frequencies are. We need to learn how important the mid to high frequencies are. We need to learn, to get back to Louis's comment, on what's the minimum requirement for cochlear coverage to produce a successful ABF. I think this is really an important and an interesting point in time. And we are far from having the answer to all of those questions. And we all need to work together to really make pitch fitting of a CI as reliable as loudness fitting and the other aspects of CI fitting today. Again, getting back to that one question, is there anything that you would like to mention, Emilie?
I think I agree with what Louis said, is in our population, bilaterally deaf patients that do only have one cochlear implant, that we have to, I am certain if I fit a patient with an insertion depth of 600 degrees and above, that the patients will perform well with an anatomy-based fitting map. But for patients between 530 40 degrees and 600 degrees, some of those patients, they do have less temporal fine structure channels. We see that some of them do have 3 channels instead of 4. So we are still finding out if this how this affects the outcome. And the question is, as Louis said, can we apply anatomy-based fitting to those patients in a way by altering the lower frequency limit or by altering the whole frequency spectrum, or can we only apply anatomy-based fitting as of 600 degrees? That's something to find out. And if an ideal fitting map, for example, for speech, is it the same fitting map we would use, for example, for music, or would it be two separate fitting maps? That's the biggest challenge up till now.
Okay. Okay. Hey, thank you very much. We're 6 minutes over time. Challenge is a good was a good final statement, I think, in a sense. Let's work on the challenge. Please don't hesitate to get in touch with any of the 4 speakers, if I can say that, with anyone in the auditorium. Get back to me if you have questions about ABF. We'll learn from you as you can learn from us. Let's work all together to make cochlear implants better in terms of perceiving pitch, so that cochlear implants are not only loud enough when needed and soft enough when needed, but that they also sound low-pitched when they should be low-pitched and high-pitched when they should be high-pitched, so that in the end the Beatles sound like Beatles and Beethoven sounds like Beethoven, and a flute sounds like a flute and a violin sounds like a violin. Hey, thank you very much to all of you. Thank you for your time. The last thing I need to do is to announce the next Experts Only. The next Experts Only is on October 30th, 2024, and it'll be on precision cochlear implantation. And you'll find email information right in time before, of course, from our, email department, so to speak. Again, thank you very much. Thank you to the 4 speakers. Thank you for your time, and have a nice afternoon and evening. Thank you very much.